Welcome to Checking In, a Scottish Rite for Children podcast, where we'll share up-to-date expertise on children's muscles, joints, and bones. Scottish Rite for Children is one of the nation's leading pediatric orthopedic centers. Since 1921, we have been committed to caring for the whole child, mind, body, and spirit. Today, our world-renowned medical staff treats a wide range of pediatric orthopedic conditions, including sports injuries and fractures. Our specialists also excel in the treatment of related arthritic and neurological conditions, as well as learning disorders like dyslexia. Through outstanding care and compassion, Scottish Rite has become a place of hope. We are dedicated to beating the odds in the face of adversity because it's our mission to give children back their childhood. And now, your host, Jennifer Bowden.
Hi, everyone. I am Jennifer Bowden. I'm a nurse clinical manager for the ambulatory care department at Scottish Rite for Children. Welcome to Checking In. I'll be your host for this podcast, where we will have an open discussion with our various experts about the different conditions that we treat. We want this to be a resource for you and for your family, whether you're a current patient, possibly need our services in the future, or just looking for information. Today, we're talking all about Adolescent Idiopathic Scoliosis, or AIS. What is it? School screenings, and an overview of treatment options, and more. So let's get started. Today, we are checking in with our Chief of Staff, Dr. Dan Sucato. Welcome, Dr. Sucato. Thanks so much for joining us today.
Thanks, Jennifer. It's good to be here. I'm excited about this podcast.
Yes. So I think, we just want to talk all about scoliosis and specifically adolescent idiopathic scoliosis. I know everybody will hear us say AIS over and over again. So can you kind of just tell us what AIS is?
Sure. We'll start from the last word and go backwards. So scoliosis is a curvature of the spine. So when you're looking at somebody from either the front or from the back, you see a curve to the right or left or both. In other words, they may have a couple of curves. So that's the scoliosis part of it. The idiopathic means we just don't know the cause of it. We are not smart enough. We just haven't figured it out yet, what the cause of this type of scoliosis. And then the adolescent means they're older than 10 or older. And so adolescent, 10 or older, idiopathic, we don't know the cause, and then scoliosis is a curvature of the spine. And it's the most common type of scoliosis we see, and so we spend a lot of time investigating it and talking about it, much like we're doing today.
Okay. Are children born with scoliosis, or is it something that develops as they grow?
Yeah, that's a common question. So adolescent idiopathic scoliosis, you're not born with it, and so it gets worse with growth, and we'll talk about how it gets worse later on. There certainly are some types of scoliosis that you are born with, and so that's congenital scoliosis, where instead of having a rectangular, symmetric vertebra, and we have a roughly 30 vertebrae in our spine, that one or more segments are misshapen, and for whatever reason during their development, there's been some shape change to the vertebra, and that results in scoliosis. So instead of having rectangular, if you will, blocks that get stacked up on each other, you may have a hemivertebra, half of a vertebra, where that is thrown into the mix, and because it's only half a vertebra, it creates scoliosis. There's other idiopathic scoliosis that probably starts really young in infancy and can develop into scoliosis, and so that's also one that starts much earlier than adolescent idiopathic scoliosis.
Do you feel like, we see it more in girls versus boys or boys versus girls?
So adolescent idiopathic scoliosis is equally common in small curves, boys versus girls. So small curves, we see roughly the same incidence, and these are statistics that are out there in studies. As curves get bigger, though, it tends to be more affected in girls than boys, and so we see probably a 4-to-1, 3-to-1 ratio girls to boys in terms of scoliosis that needs treatment and the treatment management of bracing and surgery, and so that's sort of how it breaks out from a gender perspective.
Okay. So when we're talking about just scoliosis in general, how is the scoliosis detected? Like, how do we find it?
So the first is sort of screening, and then this is picked up by many different people. The two biggest sort of healthcare providers that we get referrals from are from school nurses. And so The nursing teams in the schools and the nursing teams, even in the offices of clinicians, pick it up. In the state of Texas, there is mandated school screening that's done in the middle school. And they simply do what's called an Adams forward bend test, where the children are relaxed, they bend forward. And what they're looking for is a rotational aspect of the spine, and that goes along with scoliosis. So the second group is the pediatricians, who are very good at picking it up. So the school nurses and pediatricians, and oftentimes moms and parents pick up the scoliosis when their child is in a bathing suit or when they see them in tight-fitting T-shirts and that sort of thing.
Okay, can you kind of tell us what you mean when you say rotation of the spine? Because I think a lot of us think about scoliosis when we think about it curved, not so much twisted or rotated.
So that's a really good question. It comes up all the time. So the curvature, when you see somebody standing, the left to right sort of curve, is definitely there. So that's one plane. That's the coronal plane, the side-to-side plane. There's also front-to-back abnormalities in scoliosis. So instead of having the normal thoracic or chest round back, we all have a little bit of curvature in the front-to-back plane. They're a little less curved in that plane. And then the third plane, which is the axial plane, the sort of rotation, there's rotation that goes along with scoliosis. And in fact, if we don't see rotation, then we get worried that there's other underlying reasons for scoliosis, like sometimes you can have a little cyst in the bone in the spine that causes some pain, and so the child will twist a little or turn a little bit without the twisting, and that is not true adolescent idiopathic scoliosis. That's scoliosis for another reason. So it's important to have all three planes consistent with adolescent idiopathic scoliosis. And so the earliest sign that you see on a patient that has scoliosis is the rotation, is that axial plane curve that you see. And it's harder to pick up smaller curves in the left to right direction when you're looking at it from behind. And that's why the bend test, with them relaxed, bending forward about 90 degrees, bend forward, that we can see that much easier than when we try to look at it another way.
Mm-hmm. Gotcha. So I think, the kiddos, they get their school screenings, the parents are part of that, but why is it so important for them to come see a pediatric specialist about scoliosis?
Yeah, so it's important because the goal of scoliosis screening and the goal of treatment is to prevent curve progression. We want to see curves if they have scoliosis. We want to see them when they're small. The curves are small, and when the children are a little bit younger, because curves get bigger in two main ways. One is if you're growing fast or growing at all in your spine. And the second way is when the curve is so big, even if you're done growing, it just wants to get bigger with time. So those are the only two ways curves get bigger. And growth is the thing that really drives curves getting bigger. So if we see a small curve, then there's ways we can manage that curve short of doing surgery. And that's ultimately what we're trying to avoid, is going on to have surgical treatment for scoliosis. In addition, we want to try to keep the curve as small as possible, because the smaller the curve is, most likely, and the data demonstrates this, that the patient will do better with time into adulthood and forever, and won't need any other treatment and won't have any other issues with their spine. So it's really important to get seen early. And sometimes when we see them, we just watch them over time. And sometimes the curve doesn't get bigger, but sometimes it does, and oftentimes it does. And then we have really good methods to prevent that curve from getting any bigger.
Mm-hmm. Mm-hmm. So we talked about kind of the physical exam when you meet a kiddo, and what the physical exam looks like, actually in person at their school screening, but kind of walk us through what happens, in our clinic visits. What all we do? Do we get x-rays? Do we do another physical exam? Like, talk to us about an actual clinic visit that we would have for a scoliosis patient.
Yes. So when patients get referred here, it's important that they get really a comprehensive evaluation. And so the first thing that happens is that we really try to get a good history of the child and make sure that there are things that we might be concerned with that we pick up early. So, for example, if there's any issues with respect to sensation changes in their body, in their legs, in their arms, even in their sort of sides, their abdomen or their chest, because that indicates, well, maybe something else is going on in addition to the scoliosis. Because ultimately, we want to make sure that the diagnosis in an adolescent is truly adolescent idiopathic scoliosis, that there's not something else that could be driving the curve to get bigger or even starting the curve. And so those important questions are asked. And then a good physical exam. We want to look at their back. We do another exam in terms of the rotational aspect of the scoliosis, because that's helpful for us to say, is an x-ray really needed at this point in time? And oftentimes it is, because the pediatricians and the school nurses are fantastic about picking it up, and they know when to refer patients when there's any concern. So the physical exam is done, and then oftentimes we will do an x-ray. And initially when patients come to us, we like to see an x-ray that looks at the child from behind as well as looking at them from the side, because it's really important to ensure, again, another check on the list is to make sure that they truly look like an adolescent idiopathic scoliosis, that we're not seeing those hemivertebrae somewhere along the spine, that we're not seeing any abnormalities of the ribs on the x-ray looking from behind. The x-ray looking from the side is really important to make sure that they have the contour of their back that's normal or typical for scoliosis. Because if we don't see that, then again, there's other things that we would need to do. The nice thing here is that the images are done in sort of a new technology called the EOS machine. And the EOS was developed in Europe, and it's a low radiation system developed specifically for scoliosis, although we do use it for other things. So it's low radiation, the lowest you can have. The images are really top quality. The x-ray looking from behind and looking from the side are done at the same time. And so what that then allows us to do is, if we need to make a three-dimensional depiction of the spine, which is really important sometimes, especially for planning purposes, if surgery were necessary and other things. So that's done. And the nice thing is that we have a dedicated machine essentially just for scoliosis images, and the technicians get really good image, because oftentimes we get images from the outside that were not done at a center where patients are very much screened for scoliosis. And so sometimes the x-rays demonstrate a larger curve than reality, and sometimes it's the other way around. So we really want to get a good x-ray to really show what the curve is. And so that's the initial evaluation. And there's other things that can be done or should be done depending on those initial three things: the good history, a good physical, and then x-rays.
Yeah. That's a good breakdown. I think it's important to mention, with our EOS machine, it doesn't look like other x-ray machines, right, Dr. Scotto? It's kind of like our own little spaceship x-ray thing.
Exactly.
The kiddos, they have to step into the EOS machine. It's kind of like this, like a tube-looking machine. So it definitely looks different than a regular x-ray.
Yeah, and most kids, especially if they were in that time period where we had installed it and they had previous x-rays done with the previous systems, that they said that was really cool, because the light, it shows where the image is being obtained with the light that travels down. And it's a really kind of, like you said, a spaceship looking sort of thing. It's kind of almost like a little ride for the kids.
Yes, I agree. I think our x-ray techs they do a great job making it fun for the kiddos that are hopping in that machine. Talk to us a little bit about, I know there's kiddos sometimes that come in and they think they have scoliosis, but we figure out they don't. And so we figure out it looks like scoliosis because of a possible limb length difference. Can you talk a little bit about those types of kids?
Yeah, that's a great question. So it comes in a lot of different varieties, but that's one specifically that can make it look as if the child has scoliosis. And that's why oftentimes the image is really important. So there's many things that we look at to ensure that it's true scoliosis and not some other things. So if someone has a leg length discrepancy, as you point out, if the left leg is short, for example, then the spine will generally then tilt in that direction because the base of the spine is not level, that the left side is down, and so the patient is then sent off, so to speak, to the left. And in order to keep themselves balanced, they develop a curve in the spine to bring them back to the right. And so we get that image on this EOS machine. It allows us to look at the top of the pelvis. And if we see a significant difference, then we will, and we usually see this before they go to x-ray, but if we don't, then we'll pick it up on the x-ray. But if we catch it on the physical exam, and again, that's where the physical exam is important, then we'll send the child over to get an x-ray with a little bit of a block underneath, a little wood block that they stand on to even their pelvis to ensure that they don't have scoliosis. If the leg length discrepancy is then there, then we can manage that leg length discrepancy and not worry about the scoliosis. So that's important. But then there's other things that we look for again. And so make sure that on the history and the physical, we're not worried about something else that's causing the scoliosis. And that could be something in the spinal cord. So a little bit of fluid in the spinal cord can result in a scoliosis. A little bit of a tethered cord with the spinal cord is normally it's free, but it can be tethered, and that certainly can cause scoliosis. So those are the things that we look for. Those are the things we listen for in history. Those are the things we look for in physical exam with a good neurologic examination. If they have some asymmetry in their abdominal reflexes, which are easy to obtain, it's not painful, it's a very quick exam, then we start thinking about doing other things like getting advanced imaging.
And, by advanced imaging, you would talk about like an MRI with the family?
Yes. And so the MRI would be the next step if we had any concerns that there's something going on in the spinal cord that might be either causing the scoliosis or potentially causing that scoliosis to get worse in a more rapid fashion than it normally would. And so we organize the MRI. And in this age group, the MRI is, especially nowadays, fairly quick and allows us to look at the whole spinal cord. We also look just at the spinal cord as it comes off of the brain. And so it's important to get that image all the way up because sometimes there's other things that we need to see, and if we see them, then it's important to recognize those, obviously, and then get them off to see the neurosurgeon who may need to do something. Those occurrences are very uncommon in the adolescent age group. In the younger age group, less than 10, they're a little bit more common, and so we oftentimes, almost as a routine, if we see somebody with idiopathic scoliosis, but they're less than 10, so the juvenile or the infantile idiopathic scoliosis, those are children less than 10. Juvenile is 4 to 10, and the infantile is birth to 3 years. Then we'll get an MRI as a routine.
Mm-hmm. Yeah. And I think both you and I have taken care of kiddos that this happens in, but I think it's important to acknowledge, I think your pediatric orthopedic doctor or specialist is a good starting point because we can always help you get to whoever else you need to consult with or, to further testing. We can always help be the, kind of guidelines for where we need to start with all of that.
Yeah, exactly. And oftentimes that's true that patients come with a specific concern. And again, like you mentioned, this concern of scoliosis, where it's not necessarily a scoliosis that's the issue, it's leg length discrepancy. They have a little bit of a cyst in one of the vertebrae that's causing the scoliosis, but also can be causing symptoms. And again, we're going to pick that up with a good history and a good physical and then good imaging. And so there's a lot of orthopedic things that look like scoliosis that aren't necessarily scoliosis, but we're the ones who can see that, identify that, and get those patients taken care of either here or if they need the outside appropriate referrals, then we clearly know folks in the pediatric community that can help us and help the patient.
Right. I think that for sure, like those types of things really highlight the importance of seeing a pediatric orthopedic specialist. I mean, would you say that it's more important to see a pediatric orthopedic specialist than it is to see, say, like a chiropractor or just a regular orthopedic doc out there in the public health practice?
Yeah, I think that being a pediatric specialist, whether that's, and obviously orthopedics is my specialty and our specialty, that we know things that are important to take care of that go along with certain things. So, for example, in scoliosis, the spine is important in that diagnosis, but the adjacent joints and specifically the hips are really important. And so in the pediatric world, oftentimes we see things like hip flexion contractures because some of the muscles are too tight. And that plays a role in treatment. It plays a role in diagnosis. And that's not something that you see in the adult world. And so in addition to that, there's other underlying conditions that are associated with scoliosis that we see in children all the time. And we have the people around us that can help with that, the neurologists who are pediatric neurologists, the developmental pediatricians that are pediatric specialists here at the hospital who are really trained to see those things and help us manage those things. So, yeah, in general, children should be really treated at pediatric institutions because everything is pediatric. And it's really, we have the child life specialist that can help us in the clinic. Now, you're not going to have that at an adult hospital. You're going to have the pediatric neurologist. You're going to have the x-ray machine set up for a pediatric patient. And so there are specific doses, for example, for pediatric radiology that are far different and far lower than the adult populations. And so everything is set up and geared for that so that we can do things efficiently and safe. And the patient experience is really good. You know, we have bright colored floors, and we have kids posters, and we have children's magazines, and all the things that make the experience very good for the patients. And it's not just the technical aspect that's important. So completely agree with that.
We'll be right back after this.
At Scottish Rite for Children, our team of experts provide world-renowned care to help kids get back to doing what they love. As leaders in pediatric orthopedics, our doctors conduct ongoing research to discover the best and most innovative treatment options for each child. We are dedicated to providing ongoing education and resources to our patients and families through our blog, which highlights various specialties, offering tips and FAQs for various conditions we treat. Meet our medical staff, learn about our history, request an appointment, and find up-to-date information about news and events happening at Scottish Rite. Visit scottishriteforchildren.org to learn more.
We're back to Checking In with Scottish Rite and your host, Jennifer Bowden.
So say, a kiddo comes in and we have diagnosed scoliosis. Like, talk about some of, our non-surgical treatment for scoliosis.
So today, there are a few things that have been added to the sort of treatment algorithm that we are beginning to look at very carefully. The most traditional non-surgical treatment for scoliosis is bracing. And bracing has come in an enormous way in the 20 years I've been in practice because we've done a lot of things not only elsewhere, but we've done a lot of great research here to make it as successful as possible. So the general concept with bracing is in a growing child, and the child has to be growing in order for the brace to have an effectiveness to it, is that the child wears the brace during their growing years so that as they grow, the curve doesn't get any bigger. And what happens is the brace corrects you while you're in the brace so that during those rapid growth years, the spine is almost programmed to not get any bigger. Occasionally we see improvement, a permanent improvement, especially if the child wears the brace really well, meaning many hours. Now, bracing there's so many things that are really important for bracing. Number one is they're all custom-made braces. We're very fortunate here, one of the few institutions in the world really that have our orthotists in the hospital here. They're employed by us. They're working side by side with us here in the clinic. And so it's a team. And I'd say that's probably one of the most important things that we offer is the team approach to pediatric orthopedics. So we have the orthotists with us, the nursing team, the physicians, the physical therapists, occupational therapists. Everybody's ready to go on hand in the clinic to provide the best comprehensive care to each patient. So they're all custom-made braces. They're made in our brace shop downstairs. We use CAD/CAM technology, and so when the patient is prescribed a brace by us, or when we all decide a brace is the right option, then they get their laser optic scan, which is much different than we used to do even 5-10 years ago, where it was actually manual measurements. This is a laser optic scan that then goes into the computer, and the CAD/CAM technology then fabricates the brace to that child. And the orthotist supervises that and then makes any tweaks that are necessary, because the child then comes back, gets fit with the brace, and then they have a separate appointment with the orthotist to make sure they get all the things they need, including the T-shirts and all the things that are important that make bracing successful. The other options that are now available that we are starting to look at are scoliosis-specific exercises. And the most common is called the Shroff Method. And the Shroff Method was developed many years ago in Germany. And so we have adopted that. We have 4 therapists that are specifically trained in Shroff. And so it's yet to be specifically proven to be successful. There are some early studies that are promising that this technique is promising. You have to have the right therapist to do it. We've got great therapists that do it, and you have to be very committed to it. The patient does and the family does. We're actually the lead institution on a multi-center study that was funded by the Scoliosis Research Society to look at this, and it's a randomized study, and so far, we're still enrolling patients, and if patients don't want to enroll in the study, they certainly can have the Shroff Method separate from that study. And there's other things that are sort of, I would put in the investigational stage, including vertebral body tethering, which is something that has some promise, but is still investigational. But that's an operative measure in terms of treatment.
And going back to bracing for scoliosis, I think, and I know you've seen this too, Dr. Sucato, when we mention a brace in clinic, for the parents and the kiddos, they freak out a little bit because I think everybody tends to think about the back braces that you see in movies, that hold your neck in a certain place with horrible buckles and metal.
Yeah, right.
I mean,
exactly.
Talk about our braces now. I mean, they're so incredibly lightweight and low profile. I think it's important to kind of give people a visual of what, what bracing looks like, this day and age.
Yeah. No, it's a great question, and we could almost have a full podcast on bracing, especially because of all the things we've done here. So, what you described with the brace that goes up along the neck, that's the old Milwaukee brace, which we don't use anymore. So our braces, as I said earlier, are custom made. They're low-profile plastic braces. They're well padded, and the pads are for 2 reasons. One is for comfort, and the second is to apply a little bit of pressure to gain correction while you're in the brace, because that's one of the key things for success is it has to be a good brace. So we need to make a really good brace that gains some correction of the curve so that as the child grows, the curve doesn't get any bigger. They're all go under the arm. Nobody has to see them. Again, they're low profile. So if somebody wears their normal clothes over the top, no one's going to see it. And we have basically 2 main types of braces, and there's within those 2 main types, there's some subsets. And there's the all-day and nighttime brace, where you really wear it during the day and at nighttime, and so you can wear it while you're sleeping, so you can gain hours there, and you can wear it during the daytime. How much you wear it during the daytime is dependent on many factors, but the big ones are how much growth is remaining. So if a child has a lot of growth left, then we probably need to wear the brace a little bit more. And if their curve is a little bit larger, then we want to make sure that they're in it a little bit more. So generally, we start bracing at about 20 degrees, above 20 degrees, certainly 25 degrees. And so if someone has a larger curve in the 35 degree range, they're probably going to wear the brace more. The second style of brace is the only nighttime brace, where you just have to wear the brace at night. And so the reason we're going to choose one of those 2 methods or times in which you need to wear the brace is really dependent on where the curve is. So if it's in the lumbar part of the spine, the more flexible part of the spine below the rib cage, and the curve is relatively small, then a nighttime brace is very effective. Now, there are some curves that we do use a nighttime brace where it's a thoracic curve. And so those are the subtle things that are really important for us to work together, and that's why the orthotist is there, the surgeon, the nursing team is there, really trying to come up with the best treatment for each child and what type of brace to use. The other thing that we've done here and studied here is it's important to kind of keep an eye on the kids and really know how many hours they're wearing the brace, because the number of hours in the brace correlates to success in the brace. And so we have years ago, probably 15 years ago, developed a temperature sensor that we started to put in the brace, and it pings the brace every 15 minutes or so. And when the child comes back and the parents come back, we can download the data and get information and report back to the family exactly how many hours they're wearing it on average. We also have a bar graph that shows each day how many hours they're wearing it. So you get a sense of how much they're wearing it, and we can sort of be strategic in saying, you're doing great. You don't have to change how you're doing things, or, we need a few more hours, or we need an hour more a day. It looks like every week or so you're taking one day off. Maybe if you just, instead of taking that completely the day off, you wear it, 8 hours a day as opposed to the 16 hours a day that we're asking you to wear it, so that your number of hours are increasing. The next exciting thing that we've been using in the last year or so is an advanced temperature sensor, which is actually giving data day to day on your phone app. And that has been utilized, and we're still working out some of the details of that, but it's been actually very successful for some families because they can see day to day, and the child can see on their phone, if they have a phone, what their brace wear is, and it gives them a day to day in real time report, as opposed to waiting until they come back and the data gets downloaded. So that's where I think this concept of precision medicine comes into play, where you're really being precise in, number one, how you design the brace, number two, how you fabricate the brace, really figuring out how many hours each patient needs to wear the brace, and then getting some feedback to the family and to the patient in terms of how many hours they're wearing the brace each day.
Mm-hmm. Mm-hmm. Would you say that like the threshold for prescribing or recommending a brace would be kind of around the 25 to 30 degree curve range?
Well, it depends. Yes, for sure. That's been the traditional starting point. But I think for young children who have a lot of growth left, even above 20 degrees is a good number to start talking about wearing a brace, because the sooner you get to it, the easier it is to brace. So a smaller curve is easier to brace. It's more flexible, so probably easier for the child. And the other thing is that sometimes we're more successful because you're at a smaller degree level, and we oftentimes can stop the brace a little bit sooner. Sometimes those are things that we're investigating and looking at. They're not necessarily proven, but there certainly seems to be early data to suggest it might be better for some children to wear it 20 degrees. But you're right. In general, 25. Once you get above 30, though, we're a little bit behind the eight ball. So we really want to get to them, in the 20s for sure.
Okay. And then I know parents hear us say thoracic curve, lumbar curve, thoracolumbar curve. Can you kind of explain the difference in between thoracic and lumbar curves?
Yes. So the thoracic spine refers to the spine that has a rib attached to it. So there's 12 thoracic vertebrae, and it starts sort of right at your shoulder level and goes down to, let's call it right about where your belly button is. That's sort of the thoracic spine. Below that is the lumbar spine, and the lumbar vertebrae don't have ribs attached, and that's the segment of the spine that you have most of your mobility. And so when we say thoracic curve, that means the apex, or the most deviated vertebra in that curve, is in the thoracic spine, and lumbar curves is where the apex of that curve is in the lumbar spine.
Which one do you think is better to have, Dr. Sucato? Which one's easier to have?
So if you had to choose a thoracic or a lumbar curve, you would much rather have it in the thoracic spine in general, because the lumbar spine is where most of your motion occurs. And if you have a lumbar curve and you were to have surgery, for example, then you definitely would not be as satisfied with lumbar surgery as you would be with thoracic surgery, because you're stealing more motion segments in the lumbar spine, which are where most of your mobility occurs. So I'd say that would be in the surgical sort of scenario. But if you're in a bracing scenario, you might even want a lumbar curve, because you can have a nighttime brace as opposed to an all-day nighttime brace, more commonly for thoracic curves. So it's a hard question to answer. Most of the time, though, if someone has to have surgery, I always tell families, if you have a thoracic curve, you're much better scenario than if you have a lumbar curve.
Right. Okay. So I know, we've mentioned surgery a couple of times, and I know we've mentioned tethering.
Yep.
Can you kind of touch on the surgical options for scoliosis?
Yeah. So traditionally, the most common type of surgical option, and that's true today, is a posterior spinal fusion and instrumentation. That's a lot of words, and we'll get back to that in a second. And basically what that means is the traditional method is that we correct the spine and then hold it in that corrected position with fusion. So those segments that we're operating on become straighter and they become fused. So those are the two things we do. We correct the spine a certain amount, and then we freeze it in that position. And we do that by attaching to the spine some anchor points, some screws today. And usually the surgery is all done from the back today through an incision in the back. And then we attach to those anchor points 2 rods. And those rods and the screws are used to correct the spine and then, again, hold it in that corrected position until the spine fuses. And fusion takes probably 6 months to a year for it to be really solid, but kids get back to activities pretty quickly today. So the upside of that is a very reproducible operation that has very good success with low risk for complications. However, the downside is that you are fusing those segments. So you're theoretically taking away motion from the spine. Children and adolescents don't notice that much, especially if it's in the thoracic spine. If the lumbar spine is fused, then that's more noticeable in terms of their lack of motion and being able to bend forward to the extremes that they were doing before. But certainly from a functional standpoint, they're able to get back to doing all activities, whether it's dancing or cheer or sports or any activity. We allow them to get back to those activities. Tethering came along, vertebral body tethering came along, and it's been sort of an evolution over the last 10 or so years. And the concept there is to be able to correct the spine, but not fuse the spine. And so if you think of it sort of as an internal brace, that was the concept that was proposed. The other aspect to it, so in addition to maintaining motion segments, because you're tethering the convex side of the spine, in theory, you're allowing the concave side to continue to grow and correct the curve. So not only are you maintaining motion, but you're also correcting the curve. Now, we do this all the time in the legs when children have bow legs or knock knees and they still have growth remaining. We're able to successfully tether one side of the growth plate and allow the other side of that growth plate to grow so that the curves are corrected. But that's a much better understood growth pattern in the lower extremities. It's usually just one plane, and so it works very successfully. That hasn't been true in the spine. There are a few centers that are doing this as a fairly routine procedure, but the data are somewhat promising, but also somewhat concerning. And so I think the mechanical aspect to it, the technical aspect of actually doing the surgery is fairly straightforward. I think the problem is that we just don't understand growth as much as we would like in each child and how the spine grows. And therefore, there have been some challenges along the way. And those challenges have included sometimes overcorrection of the spine because you're putting the tether in and you're just sort of watching. And sometimes you've done it too early and the curves were too small and the child actually has a curve that goes in the opposite direction. That's a real issue that's happened. The other thing is that the tether is a flexible tether. It's a plastic sort of material that with lots and lots of cycles of motion will actually break. And so now you've got a broken tether inside, and so that has been somewhat of a problem. So those have been the two biggest problems. The third is that it's not effective and the curve just continues to worsen, and then some patients then need the definitive fusion anyway. So we have kept a very, very close eye on it. We've been part of the conversations and followed the results very closely through the Scoliosis Research Society. We have it available here, but have not really used it more than 3 cases because we have not found it to be necessary, especially in light of an incredibly successful, maybe the most successful bracing program in the country. So given those facts, although we're still watching it very closely, we have not employed it on a very regular basis to date.
You're listening to Checking In, a Scottish Rite for Children podcast.
Do you have a story to tell? We want to hear it. Sharing your experience with us can provide inspiration to other patients and shine light on our mission of giving children back their childhood. Whether you are a current or former patient or family member, we invite you to share your journey with us. To submit your information, Visit scottishriteforchildren.org/share your story.
Welcome back to Checking In, a Scottish Rite for Children podcast.
We get a lot of questions about spinal fusion versus tethering. Can you talk about kind of, with tethering versus spinal fusion, which one puts you at risk for more repeat surgeries, versus tethering versus fusion?
Yeah, so I think let's take a specific example in the thoracic spine. Essentially, the basic indication is if the curve is progressed, either because it was not seen and they progressed to a certain level, or the curve was identified and it was braced, and despite bracing, the curve just got to the curve magnitude that requires surgery, then we'll move forward with surgery. And that so big number is 50 degrees. So if curves get above 50 degrees, or we know they're going to be above 50 degrees because they're 45 degrees and the child has a lot of growth left, then they're sort of out of the bracing category. Then that's when we decide to move forward and talk about surgical treatment. So in general, and not every patient is this true, but in general, if curves are above 50 degrees, then we generally move forward with surgery. And the reason that 50-degree number is there is because we know that curves above 50 degrees, even if you're done growing, will continue to get bigger. So there's two ways curves get bigger. One is if you're still growing, and the second is if the curve is greater than 50 degrees. Then we know the curve wants to get bigger into adulthood. So if you have a thoracic curve of 55 degrees, then a posterior spinal fusion compared to a tethering, the downside of posterior fusion is you lose motion, whereas in tethering, you theoretically maintain motion. And I think that's true, that you have more motion than a fusion. But in the thoracic spine, you don't have much motion to begin with, so it's not anything that the patient sees or feels. The likelihood of you having a reoperation for a posterior spinal fusion is significantly less than a tethering. The biggest series with the longest follow-up has an almost 50% revision rate when you have a tether compared to a posterior spinal fusion that probably has a 5 to, at the very most, 8% revision rate today.
And when you say revision, we're talking about, a repeat surgery to fix an issue or to make it better or to change or revise what we've already, done with the previous surgery, right?
That's right. Yeah. So for tether, for example, the common revision would be the curve has continued to get worse, and therefore we need to go to a definitive fusion, a posterior fusion. The other reason is that, if you have a broken tether, then you can make a decision to either replace that tether and go back in and do surgery and hope it doesn't have any other problems, or go to a definitive fusion. And if you have overcorrection, so those are the big three, overcorrection, continued progression, or breakage of the tether, then those all require surgery again.
Mm-hmm. And definitive fusion. I know we like to use the phrase around here, kind of one and done.
Yes.
One and done surgery. So I think, when we say definitive fusion, that just means, that's it. That's the answer to the question about the scoliosis. We're going to definitively fuse your spine and be done. Yeah.
So definitive fusion, one and done, it means that, we attach the anchor points, we attach the two rods, we get correction at the time of surgery, and nice correction. Today, we probably quote somewhere between 65 and 80% curve correction, depending on many factors. Sometimes we don't want to try to get too much correction. We can talk about that. But usually we get nice correction, and the spine then stays corrected, fuses in that corrected position, and then we're done. And the child gets back to full activities, generally depending on where the fusion is and what those activities are, somewhere in the 3 to 6 month period of time. And they don't ever have to have anything done again. And that's, again, the most common scenario for sure.
Okay. So we've talked about non-surgical options. We've talked about some surgical options. I know we get this question a lot, Dr. Sucato. People come to see us and we diagnose the scoliosis, but they say, what happens if we don't do anything? What happens if we don't, try PT, if we don't do a brace, if we don't go for the surgery? What happens if we don't do anything?
Yeah, and that's probably the most important question that to answer in terms of when you're deciding about surgery, because it always comes up. And so I view it as, okay, where would you be today with surgery versus without surgery? but just as important and perhaps more important, although it's difficult for adolescent kids to sort of think this way, is where you're going to be 20, 30, 50, 70 years down the road with surgery versus without surgery. And that's really the comparison to make. And so we always make that comparison. We always go through that thought process, even right up until the day of surgery, to say, is surgery the right answer for you, depending on many factors. And I think the challenge is and we're fairly conservative in terms of when we say this is an indication for surgery. The reason is that we want to make sure that we're comfortable that we know that curve is going to get bigger if we didn't do surgery down the road. And if that happens, and curves get bigger above 50 degrees, even if you're done growing, about on average 1 degree per year. So if you have a 15-year-old child who has a 55-degree curve, 20 years down the road when they're still very young at 35, they may have a 75-degree curve. And the problem with those kind of curves is, number one, pain. And so a child and an adult at that point is going to potentially have significant pain. Pulmonary function gets affected above 75, 80 degrees. And so the pulmonary function can be diminished. And those are the two big ones that happen over time. And so debilitating pain can happen. Pulmonary function issues can happen. And so those are the reasons to move forward with surgery. Now, there are some curves that never get much bigger than that 55 degrees, especially if there's a balanced thoracic and lumbar curve. And so someone who has both a thoracic and lumbar curve, if they have a 55-degree curve and we've watched it and it stayed stable, that's probably better to watch that curve over time than to do surgery where we're doing fusion of both the thoracic and lumbar spine. And by the way, that can be done at any time. It's certainly much easier to do it when they're younger than when they're older. And so that goes into the consideration in terms of when to move forward with surgery too. So, and then the other aspect is really the third part, in addition to pulmonary function back pain, is really the visual appearance, the cosmetic appearance of the back, because as the curve gets bigger, it certainly can be seen much more easily. And certainly cosmesis and body image and those sort of things are really important to everybody. And so that's another factor that goes into the decision making.
And so, if we have a family that decides, not to work with physical therapy or, wear a brace or have surgery, any of those options, it is important to remember, we will keep an eye on you, talk about how frequently
Absolutely.
we would monitor, that curve or, get an x-ray or see you back in clinic, kind of talk about how we handle that type of situation.
Yeah, so this is that's a great question. This is a group decision. This is shared decision making, as some people call it, and we will do our very best to, as a team, to educate patients and families to say, these are the data. This is the latest, and things are changing all the time. We contribute to the research that's being done, and we're always trying to get better. That tomorrow we want to do better than we're doing today, and the only way to do that is to really ask good research questions and have a good research engine that tries to answer those questions. And so in shared decision-making, we want to provide as much information about their child, the scoliosis that they have, and trying to make the best decision for them, not only now, but as I said earlier, into the future. Where will they be many years down the road, comparing surgery versus no surgery? So if someone ultimately says, listen, we want to wait, we want to sort of see what happens, we're at this point in time, we're not comfortable moving forward with surgery, then I think that's a very fair, very reasonable decision. But it's important to continue to follow, because that may change with time. The curve may change with time. Their perspective may change with time. Our perspective may change a little bit with time. To me, the most important thing is that families are comfortable with their decision. And if they're not comfortable, there's no rush for surgery. If some people say, if parents say, and the child says, we're just not ready. We may be ready in 6 months, or we'd like to come back and chat about this again in 6 months, get another x-ray, then that's a perfectly acceptable thing. There are times where the curves have really progressed and the child is growing very quickly that we tend to say, that's fine, that's a good decision for now, but let's catch up maybe in 3 or 4 months rather than 6 or 9 months. And so we want to be certainly open to everybody's. It's ultimately the parents and the child's decision whether or not to move forward with surgery. We want to help guide them to make a good choice for them.
Well, I think that was an excellent overview of scoliosis and what we do for scoliosis. Before we wrap up, though, I did want to ask you a couple of questions that we get all the time that I think you're very familiar with. When talking about scoliosis, in the child or adolescent, does scoliosis hurt? Is it painful? Will it cause pain?
So that's a good question. And so the answer is we probably 30% of the children, adolescents that we see with scoliosis have some component of pain. It's certainly one of the things we ask about. And we don't think it actually causes pain. It certainly can accentuate some back pain that they have. But most of the time we can treat that back pain with good physical therapy exercises, a multidisciplinary approach. We see many children who don't have scoliosis that have back pain, and so we can effectively treat that before any treatment for scoliosis. And we certainly want kids to be in better shape with respect to their back and their back pain before surgery or before even bracing. So that's important.
What about backpacks? We get that question a lot. Do backpacks make scoliosis worse?
The short answer is no. We don't know of anything that makes scoliosis worse, nor do we know anything that makes it better. So physical activities, backpacks, certain sports, certain yoga, people ask those questions all the time. Chiropractic medicine, we don't know of any chiropractic medicine that makes scoliosis better nor worse. People ask about, should we go see a chiropractor because of our back pain? My answer is that if it makes you feel better and your back pain better, then absolutely seeing the chiropractor if you want to do that. And the costs that are incurred in doing that, that's great. But don't take your eye off of the focus of doing good core strengthening and hamstring stretching and a physical therapy program that we've prescribed to you. So backpacks and specifically, and back pain oftentimes comes up as a question in backpacks in which you're wearing, if you just have one strap on your shoulder, and if it's a little bit loose, can have some back pain associated with it. So, but it doesn't affect scoliosis. So we would recommend when using a backpack, especially if it's a heavy backpack, use both straps, strap it on pretty tight so it's close up against your back and not hanging off, because that can cause some back discomfort.
Hey, good advice. Good advice. Well, I think I've highlighted all of my most important questions. Dr. Sucato, is there anything that you feel like we didn't talk about that's important to mention at this point?
Well, you did a beautiful job asking all the great questions. I would say one final sort of thing is that the one thing that we're very proud of here is that it's very much a team approach, and everything is in-house here was the other aspect to it. So we have great team members. Everybody contributes to the benefit of the child. So, for example, when children go to surgery here, they're pediatric everything. There's pediatric spine surgeons, there's pediatric nurses, pediatric anesthesiologists. We have a pediatric spinal cord monitoring team. So spinal cord monitoring is critically important for spine deformity surgery because it keeps us safe. Most institutions outsource that to companies that do that. But we have our own folks that do it in-house, backed up by our neurologists. We actually ourselves as surgeons look at the data. So it's a team approach. And then the scrub techs who assist us in the surgery, the circulating nurses, all pediatric folks, and all with one mission to make children better. And as we say here, give children back their childhood. So I think that's really important for people to recognize and understand.
Yeah, I agree with that. And I think for sure, the whole team, the people in the OR, the child life therapists, our psychologists, your doctors, your nurses. I think everybody here is very focused on individualized care for each family. And we really get to know that family, get to know their needs and concerns, and really kind of take that and run with it and make the best plan of care possible, for each individual family. And I think that's something that we do really beautifully here, and we do it all together.
That's right. I agree.
Well, I've really enjoyed talking to you, Dr. Sucato. Thank you so much for sharing all your expertise and knowledge and wisdom. It was great to get to talk to you about scoliosis and AIS and surgery and all of our treatment options. I really appreciate it.
Well, thanks, Jennifer. You did a great job. I think we covered a lot of great ground, and if people have questions, just give us a call. We're happy to reach back out to you and get any questions answered. But thanks a lot. It's fun.
Thanks, Dr. Sucato.
Have a good day.
To learn more information about any of the topics discussed on today's podcast, check out our website at scottishriteforchildren.org. And be sure to subscribe to Checking In with Scottish Rite. This podcast is a production of Scottish Rite for Children. The host for this episode is Jennifer Bowden. Our producer is Maggie Dingwell. Our editor is Amy Krajewski. Our assistant editor and recording engineer is Stuart Allman. Our theme music was composed by Scott Holmes, and his music can be found at scottholmesmusic.com. Thanks for listening, and we look forward to seeing you at our next episode.